please welcome Sini Laakso.
Thank you very much, and really nice to be here with all of you. So here are some conflicts of interest. Today I'll be talking about thymectomy, because I think that's like a really mainstay of the treatment in general, and then in the second part about myasthenic crisis and a little bit also on what we found when we studied this in our hospital district. So about thymectomy. So here in this guidance paper, it's very much in the center. So when you diagnose generalized myasthenia, you should always do a thoracic CT or MRI imaging to look for, first, of course, thymoma, which is a rare cause of myasthenic symptoms, but then also to look for signs of hyperplasia. And even if you don't see thymoma or you don't see hyperplasia, still thymectomy is a really important early treatment for myasthenia in patients below the age of 50. So in more detail in the guidance paper, it was stated as follows, so that you should do the imaging and then remove the thymoma if you find it. Of course, that's a tumor that has not a risk of metastatic spreading, but more of a risk of local spreading, and usually a really good response to thymectomy for the myasthenic syndromes or the symptoms. But then in just when you don't have a thymoma suspicion, you have generalized myasthenia, you have the antibodies against acetylcholine receptor, and you're below 50 years of age, then you should have thymectomy in the early stage of the disease, with the notion that you should have a stable clinical condition before entering that operation. We will talk about that in a minute. But then if you are a bit older, 50 to 65 years of age, then it's not maybe where you start. You then try medications and see if you don't reach stable condition, then you might benefit from this as well. And then the method to be used is this minimally invasive surgery, so avoiding sternotomy, making the hospitalization usually shorter and recovery from operation much faster. But then it is important to have a discussion between the neurologist and the operating surgeon that actually you should be really careful in removing all the thymic tissue when doing that surgery. So the idea really is to really be thorough in that removal, so that the effect would come in its full. So the evidence for this operation is based on this study, a randomized controlled trial published in 2016. So there was a clear effect on reducing the need of immunosuppressants in those patients that had a thymectomy performed. And this randomized controlled trial was also extended to up to 5 years, and still that benefit remained for the early onset patients. But here, I mean, there are some caveats in this study, in a sense that it did recruit patients up to the age of 65, but then when you look at the supplement tables of the study, then actually patients older than 50 didn't appear to have benefit. Of course, then it's the same problem that I guess with the medication trials that Henning just showed, that the numbers of patients investigated are so low that lack of the statistical significance can just be related to that. But still, there seem to be this age and also sex-related difference in benefit, that it's actually the early onset women that really benefit from this treatment. And then when there have been reviews and meta-analysis on late onset myasthenia, so patients diagnosed over the age of 50, so then there hasn't been benefit in these assessments. And then, yeah, minimally invasive techniques seem to be just as good as the more invasive, the sternotomy requiring operations. This minimally invasive is pictured here. So you basically just do a sort of like a thoracoscopic approach. So you enter through the bones there and then just have a robot to assist the movement of those operating arms, and then through a video you can be going through and finding the signs of thymus there. But of course, this can be more difficult. I mean, in many patients, the thymic tissue is surrounded and almost involuted into fat tissue, and so really finding all these small islands of thymic tissue there can be difficult. So we did a small study to look at digital pathology tools, assessing then those thymus samples that have been removed in the thymectomy. And then we saw that these ectopic germinal centers, which are actually like sites for antibody production, this kind of sites you get when you have an infection in the body. It's a natural reaction of the immune system to build this kind of local antibody production sites where B cells mature and become really highly efficient to produce highly affinity maturated antibodies. But this kind of reaction you can also get in the thymus and in myasthenia. This has been many times shown that in early onset women, this is really common to have these sites, and that manifests in as a thymic hyperplasia. But then really, it really has a really clear correlation to thymectomy outcome, whether you have these hyperplastic regions or not. Well, the role of the thymus is changing by aging. I mean, you can also see it from just the size of the thymus. So in newborns and in small children, thymus is really a large organ in the mediastinum. So, but then after aging at approximately the age of 40, then it starts to lose its functions. And the main functions of the thymus are to train T cells. So T cells in their early forms come from bone marrow, and then they migrate to the thymus, and there they go through this very specific process of trying to maintain many different reactivities against pathogens, but also to limit the autoreactive capabilities of T cells, because T cells are like the key players of adaptive immunity regulation. They direct and control whether B cells are allowed to produce antibodies or mature, and then also, of course, they by themselves can be harmful in autoimmune diseases, attacking tissues and so forth. But this is like the main function of the thymus. But then how and why actually this hyperplasia focuses enter thymus in myasthenia is unknown. Might be a viral infection, might be something else, but it really seems that these thymic hyperplasia sites in myasthenia have these medullary thymic and epithelial cells that present acetylcholine receptor and produce autoimmunity within the system. So generally, there are some contraindications for thymectomy. So patients that have MuSK antibodies do not seem to benefit from thymectomy. And then if a patient is really in an unstable clinical condition, there's a lot of bulbar symptoms. Especially due to thymoma, usually thymoma is really severe in giving bulbar symptoms, then the patient should have a plasmapheresis first to stabilize the situation clinically, and then you can perform the thymectomy. because of course thymectomy is an operation, even though it would be this minimally invasive technique, still there's a risk of mortality, although it's really uncommon. Well, there was a really interesting paper last year published in the New England Journal of Medicine, so a really high impact paper on discussing health consequences of thymus removal in adults. And this has also raised a lot of discussion, this paper. So here they saw that the all-cause mortality and cancer were reported higher in patients that had thymectomy versus just cardiothoracic surgery without thymectomy. And they had over 1,000 patients in the thymectomy group and over 6,000 patients in the other comparator group. So a relative risk of about twofold for death and of cancer. Well, Elisa Kekäläinen is an immunologist in Finland, and together with Ilkka Ilonen, who is a cardiothoracic surgeon, they went through Finnish national registry data on the same topic. Of course, the numbers are much lower, only 500 patients with thymectomy, but those were then carefully propensity score matched so that they would be very much similar to those of the comparator group. And they chose two comparator groups of elective cardiac surgery and then hernia surgery to see whether there's increases in mortality. And they saw no increase in mortality in patients with thymectomy. So there has been also a lot of international criticism to this original study from the States. So of these 1,400 patients that were in the thymectomy group, then over 60% had a cancer or then a suspicion of a thymic mass as a reason of the thymectomy. So you could really need to question whether the increased risk of death is related to the underlying disease itself and not to the operation. And then, as we saw here, the survival curves seem to differentiate really at the time, at the first day after thymectomy, and then remain quite constant thereafter. So whether there could be a selection bias between these groups, that the increased mortality is so closely related to the operation itself, and the patient selection was a bit of a different time interval. So thymectomy patients were from a longer time period, whereas the control group were newly operated. So could there be differences in surgical procedures, and would there be an effect to the intraoperative mortality? And there didn't seem to be excess mortality coming later on, so this also is a bit pointing towards more of a intraoperative issues here. They suggested that there would be an impaired T-cell population replenishment as the mechanism behind this effect, but they investigated T-cells only from 2% of patients, and then it's also quite unlikely a mechanism as naive T-cells are really long-lived and shouldn't be able to disappear in a day, and then it doesn't really fit the picture of increased mortality at the very first day after operation. And then there has been some studies on Myasthenia gravis patients and thymectomy, and in these studies there hasn't been seen any increase in cancer, even in a contradictory preventive effect on extrathymic tumors. So clearly, many neurologists in the literature seem to think the same way that I do, that really this is not really showing that myasthenia patients shouldn't be thymectomized, but that there are really many problems in that study design. But of course, a thing to be taken into consideration, and then I think given the role of the thymus being really much stronger and important in children, so giving maybe extra consideration for pediatric thymectomy is good. But of course, I mean, also in children there has been benefit from myasthenia gravis from thymectomy. So even there, it should be still one of the tools that you can use. So then the other part, so myasthenic crisis. So it is the most severe life-threatening manifestation of myasthenia gravis. So here you need non-invasive or mechanical ventilation and supportive enteral feeding and ICU management. So literature says that it's about 10 to 15% of patients with myasthenia that get this kind of a crisis, and it is usually an early event that within the first 2 years of disease course, it usually takes place. Patients with late onset disease, a thymoma, or these MuSK antibodies, or then with a severe disease at onset are more at risk for a crisis. And respiratory infection is a very common trigger, but then in many cases you can't really pinpoint any triggers. Mortality has been reported to be less than 5%. So we did this study in our whole hospital district. So we covered many hospitals in the area, do this kind of a data lake search for all patients treated in the ICU, and then separately looking at patients that have a myasthenia diagnosis, and then combining the two to see how many myasthenia gravis patients have been in the ICU from 2008 to 2021, and then comparing those patients to patients that have never been in the wards or in the ICU, just in the outpatient care setting, and then to patients that have been in the neurological ward for episodes of myasthenia exacerbation. And then we also took a group of asthma patients as a comparator for the ICU patients, so patients with asthma who have been in the ICU. So we basically just of these 577 patients with myasthenia in our hospital district treated during these years, only 6% had ever needed intensive care, which is, I think, a nice thing that it seems to be lower than what has been previously reported in the literature. So a rather recent cohort, so possibly we are more active in giving treatments to prevent the crisis. And there were really early events in the follow-up of these patients. So a median of 5 months from diagnosis was the time point of intensive care. And in many patients, it was actually the first presentation of myasthenia. So they were in the ICU with ventilator dysfunction, and then we started to look into what could be the reason for that, and then myasthenia was diagnosed. And patients needing intensive care were older than those that never needed intensive care or ward treatments. And then infection was the primary trigger, so for nearly half of these cases. In hospital mortality was similar, that was reported before, so 4%. And then looking at 6-month mortality, it was clearly higher for myasthenia compared to asthma. So I think this also confirms that you need to then do more effort for the medication, the therapy, if a patient has been in the ICU for myasthenia. So then you need to really be active in the immune treatments and so forth to prevent the excess 6-month mortality. And significant risk factors for ICU treatment were thymoma and female sex. So again, thymoma requires a lot of attention at the very early stages. And interestingly, this female risk factor came up. For the treatment, so the guidance paper states that, you need to, if you have early signs of myasthenic crisis, you need to be then alert and to think about having the patient in the ICU even before a clear need for ventilation. To then manage the situation, because the loss of ventilatory function can be really sudden. It's not just the respiratory muscles, but also the ability to keep the airways open, so it can be really, really, very sudden, and to prevent mortality, then the patient should be transferred to surveillance early on. And we saw plasmapheresis and IVIG as the common treatments needed, and then enhancing immunotherapy to be important. And here's just a summary of the evidence for whether you should use plasmapheresis or IVIG for MG exacerbation or myasthenic crisis. And well, there are many studies where there was no difference, but then maybe a bit of an effect for a faster recovery with plasmapheresis, and therefore they are the primary treatments, the choice should be made based on availability at the center where you work and where you are admitted to, but then often both are good, but then maybe a plasma exchange has a bit of a more support as the first line. And with that, I'd like to thank and welcome you to Helsinki. We had last summer in June this EAN Neurology Congress of the European Academy, and as it just was announced, we'll have it again next summer. So, so you're welcome to come visit us also for that. And thank you.
Thank you so much, Sini. Once again, we now have the privilege of asking questions about what we just heard. This wealth of fascinating information. Yes?
Thank you so much for this information. I'm curious about how you evaluate the patient for ICU care. How do you measure it? Because here we have very conflicting,
tools. Yeah, that's true. It's really important, and I think this is also a caveat that you have a junior resident at the emergency department, and well, whether this is something to really focus on or not, what can you do? Should you put the patient in a regular ward or straight to the intensive care? Or so one really a key test is to see how the patient can elevate their head from lying down, because if you have weakness in the neck, that's usually a sign that you have bulbar weakness significant enough to really be cautious with the patient. And then well, of course, it's also something that you can then, usually recommend to be more cautious than not. And then the following day, you can have a reassessment of the situation at the ICU. And of course, ICU is usually quite full, so the anesthesiologist also asks us every day whether we still need ICU follow-up. But then that would be my advice. But then, of course, bulbar symptoms are the key in risk of crisis.
Thank you for your lovely speech. I was just wondering, because you have presented this wonderful data, that there are also the data that you haven't presented. For instance, what does your gut feeling tell you about if you look into the patients that died? Were there something that could have been done to prevent these deaths? Obvious reasons that you see within the medical records.
Yeah. So there were patients that had several ICU admittances in a bit of a row, and there you really started to think that why wasn't anything done? In between. So surely there has been cases where less was done than what would have been needed.
Did you calculate the repeated ICU admissions as a risk factor? Or?
There were so few patients that it didn't really, we couldn't reuse it in that model. But also, there has been, I think, a bit of too much of use of corticosteroids for myasthenia exacerbation. Of course, with a lower dose, and I mean, for other than bulbar symptoms, that might be an option. But then there was at least one case that had quite severe bulbar symptoms, and when this was prescribed at the ward to have methylprednisolone IV pulse, so really, really high dose, and that was clearly a wrong decision, because we know that high doses of corticosteroids often worsen the myasthenia symptoms at first, and then only later on they start to give benefits. So that's and also a clear demonstration in this patient that ward is not the right place for this kind of combination. You don't have surveillance all the time, and then it can be like mislooked and so forth.
Thank you, Sini. Do you think now with the newer immunosuppressive, you didn't say that, immunosuppressive therapies, we will reconsider the role of thymectomy in the future, except for those, of course, who have a thymoma?
Yeah, so of course there's not that much evidence on that. There's Valentina D'Amato, who works in Florence, just commented that they had looked a bit to patients that have had rituximab and then undergone thymectomy thereafter, and then they couldn't really see a loss of the hyperplasia. But then I hear that maybe in Karolinska they have some cases where that has been shown that rituximab could sort of like be like a chemical thymectomy in a sense. So it's really an interesting idea and worth investigating further. Yeah.
Yeah, I think there will hopefully be studies to show that, but for the future. Yeah.
But at least it's been shown for like these autoantibody mediated diseases like neuromyelitis optica and that NMDA, neuromyelitis optica, that with rituximab you do clear the antibody production from the lymph nodes. So that's of course a promising sign that rituximab would have this kind of potential.
Can you maybe talk a little bit about the measurements that we use as first-line measurements when you come into the ER or something, or into the ward? Because we are measuring life signs, we're measuring saturation, oxygen saturation, that we here know that is not the first thing that goes. Yep. But some people here might not know how MG worsening is and how we slip into a crisis.
Yeah, so we usually advise that the patient needs to do these, how do you say it? So forced vital capacity, so measurements, breathing tests at the ward. So yeah, every 3 hours, every 4 hours, and we need to have them written down on a paper, and we follow up. Is there a decline on those values? Of course, that doesn't completely capture the risk. So yeah, so of course, I mean, usually it's a bit assessed, like the muscle weakness is assessed and so forth, but then we have written in our in-hospital guidelines that you should sort of like really focus on the bulbar symptoms, and if you have them, then just be more cautious than take risk. Yeah.
And then maybe not focus so much on the oxygen saturation
as
that's
we true.
tend to do.
Yeah, that doesn't help because, of course, yeah, it's not just the function of the lungs, actually, like the lung tissue functions normally, but then the muscles opening up those airways, and then especially capability of keeping up the airway so that you can't really at all capture with oxygen saturation. Yeah.
I also have a question about the thymectomy, because as you can see here with many of these talks, we are focusing on AChR antibody, like positive AChR antibodies. And with the thymectomy for seronegative, double seronegative, those that don't have MuSK either,
So yeah, we do that if it's maybe not in the first line, but then if we see that we don't get an optimal response from medications, so then sure, it's something to be considered. It's related to the diagnostic testing. I mean, we use these methods that are not the highest of sensitivity. I mean, it would be actually like a live cell-based assay would be the highest, and we don't have that available. So there's always the risk that we don't really find the antibody, although it is there. Yeah. So if it's a generalized disease and it's MuSK negative, then you could think that most likely there will be benefit. And of course, for MuSK patients, then rituximab is pretty much the first line because it's IgG4 class antibody, and that you really capture really well from the blood circulation with rituximab. So those B cells are well taken out.
It seems like that concludes the questioning for Sini. Can I invite you all to give her a warm applause?